Okay. Can you see Dr. Tracy on your end if it's recording? Because I press record. Oh, yeah, it says pause or stop. So it's recording.
Hmm?
Okay. Hello, everyone. Today I'm speaking with you and I'm asking if you could participate because I noticed that in this assignment it's asking for participation. So you might ask me a question or two, maybe give feedback or some perspective on the topic. So feel free, to go as you please. It's an open door policy for this presentation. So Luz Garcia-Pennock. I'm speaking about generalized anxiety disorder, GAD, and two other related disorders, which is panic disorder and obsessive compulsive disorder. And this is for psychopathology and holistic health, 611. So I'm going through the agenda. So we're going to go over some highlights of the topic, symptoms of GAD and diagnosis, the etiology, evidence-based treatment, biblical counseling perspective. Also, two cultural perspectives, one from USA and one cultural perspective from Mexico. And then we'll compare with OCD and panic disorder and conclude. So I'll get started. Well, my question is, as I look to do a presentation in a way that's engaging, I thought, well, what question could I ask, right? And my question is, when you think about the words generalized anxiety disorder, anxiety, what comes to mind?
Okay, so I'll start. Someone who's really nervous.
Yeah, that's correct. Yeah, and actually you touched on something that we're going to talk about in Mexico. That's how it's called nerviosa. You
Oh,
have nerves. Yeah. So yeah, that's a interesting perspective that you shared because we're going to cover it. Okay, so we'll all have a little more time to participate in this 10-minute presentation. So GAD is a common mental health disorder characterized by excessive and persistent worry, right? It continues and continues. It's in a loop. It affects 6.8 million about of people in the USA. And out of those, 40 or in the early 40s is people that are actually being treated, the percentage. So less than 50% of people are actually treated. So this is part of a family of anxiety-based disorders. And the other two that we'll talk about in comparison in the panic disorder and OCD, obsessive compulsive disorder. So I have a story about GAD. So, it's something that I have had since I was little. My story, it starts being at a church, trying to listen to the sermon and noticing that I'm picking at my fingernails and I'm actually like not biting them, but picking the skin off of it, you know, and I couldn't even like focus on the sermon. And I thought something's off, like what's going on? And through different years of my life, I think about the little girl that did that. And I really wonder why. And there's a couple of things that, I think that what happened in my life that led to that. At the end of the day, I live a grateful life and I'm happy that I've gone through treatment since then. A couple of years ago, I had something that happened to me that triggered where I couldn't function anymore. For years, I worked in HR and I was successful, high performing, trying to be perfect, masking the generalized anxiety. But 2 years ago, I worked at a place where it was unbearable to be able to feel that I could be myself, just the environment. So I started therapy, I started medication for the first time in my life and I could tell you that, for me, it has made quite the difference in my life. Like I don't constantly worry the whole time, about what might go wrong at work or, mainly that was like my trigger with work. Yeah. So God has been pivotal in my journey as well. If you have any questions, jump in. Feel free to jump in. So the highlights is that GAD is a prevalent disorder that, where you worry and it's affecting your daily life. It's not like there's something wrong going on that one ought to be worrying about. So work might be going well, but you think you might be failing. You have a home, you're paying the bills, but you might worry that you're going to lose your home. So it's these cognitive distortions, correct? So the DSM criteria calls for the symptoms, which will go in the next slide, that they need to be going on for 6 months or more. So it's very interesting, and I'm sure with a lot of other disorders, that there's the genetic, neurobiological, and environmental factors that contribute to GAD. Right. So it's like a whole chain of events that happen through the brain. CBT is the gold standard treatment for GAD, and we've learned that through our classes. And then there's the cultural beliefs from different cultures. As GAD has high comorbidity rates with the family of illnesses, which the siblings could be OCD and PD. We have faith-based and approaches that we could follow. And I'll go a little bit faster so I don't stay here for a long time, affecting our time. So the code for the DSM, it's in the 300th, which is the anxiety family related codes, and it's F41. And there's persistent worry, 6 months of more. And then the symptoms are the following: restlessness, fatigue, concentration difficulties, irritability, the muscle tensions from, the irritability, the sleep disturbances. There's the hyperactivity in the amygdala that's linked to the excessive fear response that we go through. And right now I'm trying to see if I could see the top points that I have. So when we think about the brain, we can look at the different factors that affect the brain and then to the point that we're anxious. So one of them first is either genetics or environmental factors like going through trauma, right? That change the structure of the brain that lead to the overactive amygdala that then creates the chemical imbalances that are affected when we have a trigger because we have these imbalances. Then when we get triggered, then we have that impaired stress response in the body. And then there's also the cognitive distortions, right? Where we're seeing things different than they might be. What else? So genetic predisposition. So, and we talked about that. About 30% of that is genetic. And then the neurobiological factors that I explained above. And then the environmental stressors like childhood adversity experiences.
Can
I
I
think
just ask
that,
one question?
yeah, go for it.
Okay, so it's since it's genetic predisposition, can you tell at what age approximately that you would have that?
It's interesting because I know for me, I only I remember when I was about 9, and what I remember that I was teased at school, teased because I was chubby, and then we didn't have a lot of money, so my mom would constantly wash these 2 dresses, and then sometimes I would just wear the uniforms in the evening, would just keep them so I would have something to wear and not wear the same thing every day. So we didn't have a lot of money. We were really poor. We always had love. But, then my parents would also, like, once in a while, they hit you with the chancla, with the shoe, or with the belt. And I think different things happen, but not until I had that cognizance of, I think I'm not okay. But I don't know, Dr. Tracy, if you have perspective of at what point can people tell therapist?
Well, the thing of it is you can see markers of anxiety in childhood. When it becomes full blown, I mean, it becomes like it can really affect the functioning of a child. Again, what's real important is to look at um, their health their environment, if there's any abuse going on, so them holistically what's going on. But you can see markers in childhood, and of a very anxious child or one with the disorder. It can happen in childhood, or it could get full blown in adolescence or adulthood. So I don't know the exact age of when you can see the markers. I would think, though, that I know I've seen it in children as early as, and again, this is my experience. I don't know the statistics, but I've seen it. I saw a 6, 7 year old that displayed a anxiety to the point where you could see it as a generalized anxiety disorder. So again, I think that's a really good question. And for all of you, maybe Wendy, if you could even, or Luce, if you could look that up, not right now, but
Yeah.
if the literature does say when markers do exist that could indicate further the syndrome in adulthood, that would be great for us to know, especially
Okay.
when we start dealing with kids, right?
Yeah, I could
Thank
bring
you.
it, and maybe Wendy too, and then we have two different sets of information for maybe next Thursday.
That's a good question. I'm sure there's
Yeah.
research about that out there.
Yeah. Okay, next slide. Okay, so evidence-based treatment for GAD is, CBT. That's the gold standard. And a quick example is this lady who I wrote on the paper about. Her name is Juanita, and her performance reviews are stellar, above right expectations, and her conduct at work. Yet she's worried that she might get fired, laid off, which we can't control the layoff part, right? And then due to that, she is having trouble sleeping. She's highly anxious, right? So then through conversation with the therapy, she identifies the statement that she keeps on retelling herself, and they work through conversation, talk therapy, and journaling to restructure, to identify the thought, number one, question it, number two, and then restructure that. So that way she could tell herself a different story that is actually true. So that's an example. So exposure therapy is someone that has an illness and is like health-oriented anxiety and thinks I might be dying, but then they don't actually go to the doctor, but they keep on looking up information about, what disease they think they might have. So then the therapist helps them understand what's the worst case scenario, and then they write it down, and then the person feels the like from the outside looking in, this is how I feel when I feel the uncertainty, and gets used to and feeling more comfortable to know that there's nothing going on right now, I'm okay, and then starts making doctor's appointments, such to be more proactive. So that's just really high level. So two medications that are very popular. Well, one of them is Lexapro, right? It's the first line treatment. And another one that's not there is Buspar, which is less codependent. But Buspar is more for anxiety, and Lexapro is for both anxiety and depression. I was taking Lexapro, and it was affecting my memory for the time that I took it. So I exited from that program, and started Buspar, and it's going great with Buspar. Yes. So a combination of therapy and medication is highly recommended. It works well. It actually changes the amygdala, in studies, either like alone or together, they start changing that, within changes the chemistry of it and the way that the brain sends the signals, right? So biblical counseling, just a little bit about it. It's faith-based reframing, where is someone that's a believer of a Christ, of God, right? Or they could use it with different beliefs, like if they believe in Buddha, right? For instance, let's say I'm telling myself that there's uncertain times, just like the lady, how am I going to pay the bills? really the word, then the sentence that I might work around and journal would be, let's trust God and surrender to God. And then within that, then you are taking some actions to be proactive, right? So you're working through God, but then you're creating your own destiny, basically. So integrates the Bible with basically the reframing as in CBT. There's organizations that can provide the support as well. One of them is the Association of Biblical Counselors. So if let's say you have a client that wants to work with someone that might only focus on that approach, then you could recommend it to that organization. Cultural perspective in the USA, GAD is accepted, yet about 40% of the people are on treatment only who have it. And one aspect from Mexico that's really unique, that in Mexico it's taken more of a spiritual journey in a temporary element. So in Mexico, it's like, oh, you have nerves, like you're feeling nerves, nerviosa, you have tienes nervios. So then you might go to the healer, like a full healer, and then they do a cleansing. They actually have these like it almost looks like branches, and then they heal you. They might throw salt on you, but you don't believe that it's not part of Christ. It's interesting because it's almost like supplementary. You might pray to God as well. It's not seen like it's something dark. It's almost like a cleansing, like a ritual, like meditation. So, what are barriers to being able to have therapy, for instance, or accepting God? It could be religion, thinking if I go through therapy, I'm not trusting Jesus or God, as opposed to saying like God created this therapy or, approach, and the therapist has the gift of that to help me. So it's like if I limit myself from a place of, thinking that God is not going to prove that, as opposed to knowing that God created these tools and these beautiful people to help.
And that's, Luz, that's really important um, if you have clients in the United States who are very traditional Mexican and they come in for treatment, is really understanding that perspective is very, very important. Is that of their culture, they're coming from this perspective and they might question or not be trusting at first some of your treatment. And it's not that they don't trust you, they just aren't, it's more of a cultural issue. And that's really important to think about because as a therapist, we need to understand the person in context where they're coming from, that multicultural aspect to them, and working with them collaboratively so you increase the rapport and the trust level. And instead of rejecting that, and I'm not saying that any of us do here, but something to be aware of, we embrace it and try to help them with that.
I see. So then asking the client what they might have within their traditions, right, that has helped them with, let's say, being anxious or what you might be going through.
What
Yeah.
is their perspective on what's going on with them?
Yeah.
Sure. And they might, indeed, in the case of the example here, they might talk about some of the medical, the cleansing aspect, the fold cleansing and such. And I think that we have a responsibility to talk about that with them, letting them know that what we're able to do, but also listening to them and getting their perspective about what they feel is going to work for them and having that dialogue. I think that's really important. And it could come to a place to where maybe they decide that they need more traditional interactions or interventions within their culture to really help them, or they might use that in conjunction with what you're able to bring, in your training. So it's having that open mind to that, I think, is so important for the client.
Yeah, I've seen it I've seen it where people go through the healers and then they're like, okay, it's not really working. Let me go to Western type of doctor, Western medicine.
But I think psychoeducation
Together.
is important,
Yeah.
you know. Anyway, I know you need to move on. So
Okay. So panic disorder, it's sudden recurrent panic attacks with intense psychological symptoms. I had a coworker. There was about 20 of us going through a leadership training at a center outside a business center that allowed us to have the training for free. He just walks out of the room, right? And the next day he goes, Luz, he goes, I'm sorry. He was going through something that totally changed his life, but I'll tell you the ending at the end. Yeah, so it was interesting to see how one action could derail this person's life. So he had a panic attack, full blown, and had to just run out of the room. Uh, GAD, as opposed to it, it's the worry that's persistent, but you don't have these sudden panic attacks unless you have the comorbidity, which about 50% of the cases have both. So it's pretty high. Now, if we look at obsessive compulsive disorder, where somebody might be obsessed that they might get an infection, so then they have the compulsion to wash their hands, constantly, let's say, a big part of the day, and that helps them then, quote unquote, reduce that distress from that worry that they might get really sick from an infection. Then as opposed to GAD, which you're worried, constantly or excessively. And there's a correlation of 30 to 50% with people that have OCD and then GAD. So
also note that with GAD, it mentions their real life concerns. A lot of times in OCD, they will ruminate and worry about things that um, they know that they shouldn't be worrying so much about, or the rituals that come along with that. They know that but they keep doing it anyway, right? With GAD, they do worry, but it's more based on real life concerns that feel out of their control, but it's not like they do the rituals that are involved in that. They more obsess, they ruminate, okay, but they don't do some of the rituals. They don't do the rituals that say people with OCD do. You know what I mean? Like
yeah,
touching objects or counting or going around the room a certain amount of times or touching locks a certain. Those are certain rituals that OCD, and that's just a part of the
Quick
disorder.
question is, I've been thinking about this. It seems like worry itself is a compulsion resulting from trying to quell anxiety.
Usually, it's worry. How you're describing it, it's more of an obsession. Okay, the compulsion is the action. The obsession is the rumination of the thought. You know, um, but the compulsion would have more to do with the action that you have to um, check the locks a certain amount of time in order to make sure you're safe, because in your mind you're saying, I'm not going to be safe, I'm not going to be safe, I'm not going to be safe. You see what
So
I mean?
GAD can have the obsession, but GAD doesn't have the compulsion. As that's the
Yes.
difference between OCD and
Typically,
GAD.
typically is what you see. I mean, that's it. That's a very basic way of looking at it. Yes.
yeah.
And
Okay,
it's
I don't want
very
to take away from you.
pervasive.
I
It's
know you're
very
running out,
pervasive.
I know you're running out of time. I'm sorry. Um,
Oh no.
because you know how everybody says, "Oh, you have OCD, you have OCD."
Yeah.
Because you want to clean your house, you want your house clean.
It's
But
like
that's not what it's about, right? It's about like, okay, you take I'm just asking. So you take a certain thing and that thing you focus on. It's the one thing. Like Dr. Tracy was saying, right? It's about locking the door and you turn around and go like, "Did I lock the door?" Lock the door. Make sure the door's locked. So that's what OCD is, right? It's not about my house has to be clean before people come.
that
Is
one
that
is
more
that
right?
one is different, right? I know through the Taylor study method, I don't recall the other one, but it's like it's it's something personality, but it's something about that describes somebody that wants to clean their house a lot, but it's not OCD, but it's the terminology is almost the same.
You can have obsessive compulsive personality disorder.
Yes,
You
that
can
one.
have that. Yeah,
Okay.
where it's more pervasive.
Okay.
But yeah, I mean, that's it. That's the basics of it. I encourage all of you to look at OCD with GAD in comparison, you know. But look at the comorbidity, 30 to 50%. Somebody with that has fits the criteria of worrying a whole bunch will also have the rumination and the ritualistic compulsions that go along with that. I'm actually treating somebody right now that has that. Very interesting.
Okay.
Okay.
Thank you.
Go ahead, Lucy.
I know, no problem. And here we could just look at a couple of data points. There's a lot of information. So we have the disorder, the core symptoms, the triggers, and the treatment. The only thing that I was thinking later, I could have added, what part of the brain is affected and how are the chemical parts of the brain affected, but it's not there. But you could see the how panic disorder is something that just happened suddenly, and as opposed to obsessive compulsive disorder, we have the intrusive, irrational thoughts. And then the person with OCD, I think Dr. Tracy was speaking to, actually knows that what they're thinking is off. Like that's not true, yet I suffer from this, like thinking that I'm gonna get infected, let's say, it's not a valid, for instance. Yeah, but I know we covered a lot of this information before, so in spirit of time, I'm gonna move on. So then, in conclusion, so we have these three disorders that, have the anxiety part that they share, yet they have their differences, but, they're within the family, and about what, 50% of them, people have both. And then we have the cultural beliefs that really allow us to, when we meet a client, to learn about them and include that in our questionnaires, in our conversation, so we could meet them where they are. And then we learn about the evidence or discuss the evidence-based treatment along with the medication being successful. And let's say, I have a little story that I'll finish in just about a minute. So the gentleman, his wife, his best friend didn't have a home, so he stayed with his wife and him, which we sometimes learn that we shouldn't do that, right? Bring somebody else into the relationship. So he was staying at the house. So the gentleman learned that they started a full-blown affair. So him and the wife had two adult kids already. So the wife left them. They own 5 homes together. So and then one day he came home. He didn't live with the wife anymore because the guy took over the house, basically. The gentleman moved in the house. So then he comes in to pick up his kid to go play Little League. And then the gentleman, his former best friend, and the man that was with his wife, he opens the door. So then this gentleman what used to play box when he was in high school. So he ends up, you know, punching the guy. The guy falls and his head on the pavement and wasn't life support. Then the gentleman, was having those panic attacks prior to that, but it changed his life. I don't know if the gentleman made it alive, his best friend, because he ended up having to serve time and we didn't see him again, but the story goes along, I think, a little bit outside of the topic, other than, our clients might be going through something, really impactful or tragic, and that's how some of something like OCD started, panic attacks started resonating with him. Yeah.
Thank you.
Thank you.
Yay, good job.
Oh, thank you so much. Let me just see how I stop recording. So I'm going to stop.